Thank you very much for the opportunity to present in this conference. My name is Dr. Mohammad Asim Khursheed. I'm rheumatology consultant at University Hospitals of Dorset, and my area of main interest is ultrasound and large vessel vasculitis and giant cell arteritis. Here are some of my associations, and what I plan to do today is essentially to briefly introduce the way we perform ultrasound in giant cell arteritis, essentially to give some introduction about the diagnosis of GCA, why should we be doing ultrasound, and look at some of the evidence base, and essentially what to scan, what to look for, and how various quantitative assessments can help in making sure that we are assessing giant cell arteritis appropriately. At the end, I will summarize, and then if there are any questions, I'm very happy to take. So why ultrasound? The key thing to begin with is that if you look at the historical aspects of giant cell arteritis management, about 10 years ago, the diagnosis and management of giant cell arteritis was very different. In the recent years, things have advanced significantly. Historically, giant cell arteritis has been a clinical diagnosis, mostly based on clinical features and presence of raised inflammatory markers. The only reliable diagnostic test was temporal artery biopsy, and temporal artery biopsy had its own limitations because it was an invasive test, and it is also quite sensitive to steroid use. If you have used steroids for a while, the changes may not be picked up. The biggest, excuse me, the biggest issue, however, has been that we have a very small sample when we are looking at when we're looking at temporal artery biopsy, we're essentially looking at a sample of hardly 2 centimeters, and it is not enough because of presence of skip lesions in giant cell arteritis. You may not be able to get the appropriate sample to make a diagnosis. Hence, the yield of temporal artery biopsy has been quite low. In the past, the mainstay of treatment in giant cell arteritis has been with steroids, and DMARDs have been used in the past with limited effectiveness. The modern treatment has changed hugely. We have probability scores like GCAPs available now, where we can amalgamate clinical and pathological features, and we can also score negatively for presence of any comorbidities, which is a big advance, as in the past, what we have seen is that because of the comorbidities, patients may have symptoms of GCA, or they may have raised inflammatory markers, which leads to an inaccurate diagnosis. GCAPs can classify the probability of giant cell arteritis into low probability, moderate probability, and high probability, and that can assist in what to do next. And that is before you perform ultrasound in the clinic, which has shown as good sensitivity and specificity as temporal artery biopsy itself. It helps both in diagnosis and monitoring of giant cell arteritis, and it has become the basis of development of rapid access GCA clinics throughout Europe. In addition to ultrasound, we have PET scans, we have MRI scans and CT scans, which can also provide additional information where required. And as far as management is concerned, we now have IL-6 targeted biologics since the trial GACTA was published. Tocilizumab is being used very commonly in management of giant cell arteritis and large vessel vasculitis. So the scenario has changed hugely as compared to what it was a few years ago. We have much better diagnostic options, and we have much better treatment options available for giant cell arthritis. So when we look at the role of ultrasound in general in managing GCA, the key things which make it a very useful tool is that it is available at the point of care. You don't have to wait for the patient to go somewhere else and get an investigation done. You can perform the ultrasound there and then in the clinic at the time of presentation when you know what exactly patient's clinical symptoms and signs are, and that can give you confidence in diagnosis. It can also be performed very quickly, and it's a non-invasive technique. It does not require surgical intervention or anesthetic. Alongside the high sensitivity and specificity, which we will discuss in detail later on, one key thing is that it reduces the number of appointments required for the patient. You can pretty much decide in a single appointment whether the patient has giant cell arthritis or not in about 70% of the cases. And they can be discharged from the clinic if they don't have giant cell arthritis. There are obviously issues, and there are cons of the ultrasound, especially in temporal artery assessment. It's a very time-consuming process. Each temporal artery scan can take up to 30 minutes, and usually the availability of time is a limiting factor in using ultrasound proficiently. Also, just like biopsy, the changes are extremely sensitive to steroids, and hence we require rapid access approach, without which the use of ultrasound could be meaningless in giant cell arthritis and large vessel vasculitis. Changes may disappear as quickly as 3 to 5 days, and hence the aim is to see the patients in a rapid access GCA clinic within 72 hours of referral. And finally, it is extremely operator and equipment dependent. The better equipment you have, the better outcome you're going to get. And the experience of the operator matters hugely in recognizing the symptoms and signs in giant cell arthritis and sonographic features of giant cell arthritis. So, do we actually need to accurately diagnose giant cell arthritis is another key question. So these are the old ACR criteria, which have been used widely throughout the world to diagnose giant cell arthritis. In fact, these are not diagnostic criteria. These are research classification criteria, and they were then adapted in the clinical practice. The criteria are very vague. So anyone who is above 50 and has a new onset headache and has raised inflammatory marker can be classified as GCA. You don't need anything additional, as you need 3 or more criteria to diagnose giant cell arthritis. This poses a major problem because a lot of conditions, like any head and neck infection or malignancies, can mimic giant cell arthritis very closely. Anyone who is above 50, if they end up having a dental abscess and the primary care physician is not looking for any other thing and they're suspicious of giant cell arthritis, the patient will be misdiagnosed. So these classification criteria essentially are not a very useful tool. They may be a good screening tool, but when you are sitting in a specialist clinic, they do not help you making an accurate diagnosis. The result is that you may end up underdiagnosing or overdiagnosing patients. And that has a big problem, because if you underdiagnose giant cell arthritis, you're leading to complications which lead to mortality and morbidity, which could be quite significant, including loss of vision and posterior circulation strokes. And if you are underdiagnosing, overdiagnosing them, you are putting people unnecessarily on steroids, long-term steroids, and most of them are going to end up with steroid dependence and osteoporosis and fractures and other complications which arise from the long-term use of steroids. So if we do not make a correct diagnosis and treat patients appropriately right in the first few days of referral, we will end up either with the complications of giant cell arteritis or complications of steroids unnecessarily in a big proportion of patients. In our center where I work, about 20 to 22% patients who have been referred through rapid access GCA clinic actually have an underlying inflammatory disease. Rest around 80% of the people, they have an alternative diagnosis or they do not have large vessel vasculitis or GCA. In a good number of patients, we are able to stop steroids on their first presentation, as they have been on steroids only for a few days. You can stop them and you can avoid all the possible complications which can arise from the use of steroids. So if we look at the evidence, the key study which has been performed in this regard was the Poole, which was published in 2016. That was the only prospective head-to-head trial looking at the efficacy, not efficacy, sensitivity and specificity of a temporal artery biopsy versus temporal artery ultrasound. And very clearly it showed that temporal artery ultrasound is at par with temporal artery biopsy. Actually, the sensitivity is much better. The specificity of temporal artery biopsy was considered 100%, but we have to keep in mind that temporal artery biopsy was taken or used as the gold standard. So it has to have the specificity of 100%. While temporal artery ultrasound in the Poole study had a specificity of 81% on its own and a good 77% when it is used with clinical assessment. The sensitivity remains higher throughout. The study also showed that if you are performing temporal artery ultrasound in the clinic, you can reduce the number of biopsies performed by 43% and save a lot of money for your hospital and for your department. I would say that that was a very early study, and currently we can save a much bigger number of biopsies than 43%. So that has not been the only study. The studies have been performed before Poole and after Poole. Some of them have been anecdotal, some of them have been retrospective, some of them have been systematic reviews and meta-analysis, but all the studies show that we have a very good sensitivity and specificity with excellent positive and negative predictive values with ultrasound. So the latest evidence that we have, you can see that if you're using temporal artery ultrasound and axillary artery ultrasound, the positive predictive value can be as high as 100% with a negative predictive value of almost 90%. As compared to temporal artery biopsy, where positive predictive value is 100% as it is considered gold standard, the negative predictive value is much lower than the temporal artery ultrasound. So temporal artery ultrasound clearly is a very useful tool, and that doesn't mean that we do not have biopsy at hand. There are still times when ultrasound is unable to give a very clear answer, and you may need additional investigations where you may still have to perform a biopsy. Whether biopsy will give you the answer or not is a different question, but we have the option available. And if ultrasound is unable to give you answer, which is again in a very small number, there are additional investigations like PET scan and CT scans and MRIs, which can be helpful. The evidence is so strong about ultrasound that guidelines around the world, including BSR, included the ultrasound as a part of GCA pathway in their guidelines. Similarly, in ACR and EULAR 2022 classification criteria, ultrasound becomes an integral part and a very strong predictor of presence of giant cell arteritis. Use score 5+ if the patient is ultrasound positive. So the clinical guidelines across the world are adapting ultrasound in GCA practice as well. So when we come to scanning in GCA, obviously the blood vessels which can be involved in giant cell arteritis, they are widespread. Classically, it has been described as a disease which involves the cranial arteries, essentially the branches of external carotid artery involving extrameningeal blood vessels. And what we know is that it is very commonly associated with large vessel involvement as well. And all the evidence that I have presented, that is essentially based on, most of the time, an 8-vessel scan. So that is the minimum that needs to be done when you are performing an ultrasound for GCA, and that includes both superficial temporal arteries, both frontal and parietal arteries, and third part of axillary artery on both sides. Personally speaking, at our center, we do some additional scanning, and we strongly recommend that because the larger the sample that you're taking, the more confident you are in making or refuting the diagnosis. So we routinely do first and second part of the axillary artery as well as subclavian artery, and we routinely examine shoulders in these patients because association with polymyalgia rheumatica is very high. Where required, we can perform additional vascular assessment and additional joint assessment, which can be further helpful in making the diagnosis. So how we scan is essentially for temporal arteries, we start right in front of the tragus, and that is where we start our transverse scan, and we put the probe in a transverse direction, and we move the probe all the way up until we get to the bifurcation. Now we know where roughly we know the anatomy of the temporal artery, and we can easily chase any bends, and we know where the branches are coming off. At that point, we can do a longitudinal scan of the temporal artery, the superficial temporal artery, and then on each segment, using both Doppler and grayscale assessment, and also do a transverse scan to make sure that we do a compression test on these patients. For axillary artery, classically, the third part of the axillary artery has always been examined, and that is because it's very easily accessible and can be very easily scanned. Axillary artery, as you all know, is divided into 3 parts by pectoral minor. Proximal to pectoral minor is first part, deep to it is the second part, and distal to it is the third part. The third part can be scanned with ease. You can scan it in the axilla with the arm abducted, and it is also easily compressible against humerus. Again, we do both with and without Doppler to see if there is any stenosis or occlusion of the artery, and we also do a compression test against the humerus. So what are the sonographic features of temporal arteritis? The classical feature of temporal arteritis is a non-compressible halo. In addition, you may get presence of stenosis and occlusion in a number of patients. The measurements that we do are key measurements of myointimal thickness that lead to further quantitative assessment of temporal arteritis. So in a normal blood vessel, you would see that when you put the Doppler on, the vessel is filling nicely with no problems or no disruptions in the column. You can measure the myointima, which will be available, will be seen in the form of a tiny halo around the column of the blood. You can measure them without Doppler as well if you have a sensitive enough machine. The second key thing we need to do in these patients is to do the compression. As you can see that when non-compressed, the artery appears round. When you compress it, you can almost completely squish it so that you can displace the blood, and only thing left would be the wall of the blood vessels, which is quite thin. These are examples of other blood vessels, the parietal and frontal. Pretty much they look all the same on the ultrasound, but it is important to chase them as far as possible because skip lesions are quite common in giant cell arteritis. This is a grayscale view where a compression has been shown with presence of a position of the intima, both sides, so-called kissing sign. And that is also useful because this streak sometimes disappears when there is acute inflammation. Similarly, in axillary artery, we do the Doppler, color Doppler scan, and then we do the grayscale, especially with tissue harmonics on. It is very easy to look at the myointima and do the measurements. And when we do the compression sign, again, axillary arteries are very easily compressible to a very small level, and you can see the streak sign within. So this is the telltale sign of giant cell arteritis or large vessel vasculitis, which is called the halo sign. The halo essentially is the inflammation of the blood vessel wall, and where there is inflammation, there is edema. Where there is edema, there is fluid, and where there is fluid, the ultrasound passes through it very easily, and these areas would appear darker than the rest of the tissue. And that is what creates a hypoechogenic halo around a column of blood. And that has to be non-compressible because this is tissue swelling. This is not presence of, there's not fluid which is displaceable. You cannot completely displace a thickened inflammatory tissue. This is in the longitudinal section. We can see the similar features in the temporal artery where we have thickening of the myointima. In this specific specimen, you can also see presence of atherosclerotic changes. You can see that the hypoechogenic area is the area of inflammation, and this is the central area where the blood flow is still maintained, and that is anechogenic and very different from the vessel wall inflammation. Similar changes seen in the axillary and subclavian arteries, and the classical, one of the classical signs of large vessel vasculitis is presence of slope sign. So the inflammatory area gradually builds up and then it slopes down again. You can see the slope sign on both sides in this specific specimen. And finally, we have the compression sign. We saw that you could completely squish the temporal artery when it is compressed. In this example, you can see that this is the uncompressed artery, and this is the compressed blood vessel where you can hardly see any significant difference. And similarly, the blood flow maintained here as this is an uncompressed artery. And when you compress, there is not a huge difference in the area of the compressed and non-compressed artery. This is an example or video example of how compression works. And you can see if the when you press it, it does not completely disappear. The artery, the hypoechogenic area stays behind. These are a couple of examples of stenosis and occlusion, not something that we should see very commonly if we are efficiently treating giant cell arteritis, but where there is occlusion, you sometimes get collateral formation as well in the axillary artery in this case, and where there is quite marked stenosis, you again can get pre-stenotic dilatation, and you can get formation of collaterals in these areas. So coming to quantitative assessment, the basic quantitative assessment essentially is the measurement of myointima, and here are some cutoff values for that. I must say that these cutoff values were taken from the Poole study, and it was a retrospective analysis, since we really need some prospective studies in this regard to find the normal cutoff values, but nevertheless, that's more of an academic question. These values are still very useful in determining what is pathological and what is non-pathological. The main thing, however, is gone beyond that, and the quantitative assessment has been improved upon. We are now using composite scoring systems. So the first one being introduced as Halo Count and Halo Scores by Van de Geest, who's working on additional scoring system at the moment. This was, again, a retrospective study on patients in Poole. A prospective study as a GCA trial was performed, and the initial findings have been published in 2021. We are about to publish the cutoff values for GCA in the coming EULAR conference as a poster. Omeract has developed their own scoring system for giant cell arteritis, which was published last year. And at UHD, we are working at quantification of compression as one of the assessment features and quantification modes for giant cell arteritis. The good thing about quantification is that you can put a number. You can get a composite number, which is not about a single blood vessel. It's not about one area of involvement. Rather, you can categorize the inflammation in general, and that can be used in the later assessments for monitoring purposes. So Halo score would go up and down if there is a relapse of giant cell arteritis. So this was the original paper from Van de Geest in 2020, which was basis of all this, and it showed very good sensitivity and specificity, both for Halo Count and Halo Scores, although these cutoff values, I don't think that we will be using these in the future, but nevertheless, the Halo Count value is still valid, and we use them commonly in the research setup, but very soon they will be available to be used in the clinical setup as well. So in summary, what we have is that sonography in large vessel vasculitis and GCA has essentially become the first investigation of choice. It is non-invasive, it is less expensive, and as sensitive and specific as temporal artery biopsy, if not more than that. And we can perform both qualitative and quantitative assessments. Like in temporal artery biopsy, you can't keep going back and doing biopsy again and again. In ultrasound, you can go back again and again and reassess the situation, and you can use it as a monitoring tool as well. We can also save a good amount of money and clinic time by using ultrasound in giant cell arteritis. It is playing a central role in development of rapid access GCA clinics all across the world, especially in Europe. And of course, it has a very central role at the moment in the research in the field of giant cell arteritis and large vessel vasculitis. Thank you very much. We'll be happy to take any questions.